Today the topic for discussion is emerging biomarkers in alcoholic hepatitis. I thought for basics for the students. What is alcoholic hepatitis? It is a clinical syndrome of jaundice, anorexia, right upper quadrant pain and tenderness, and with the presence of surge systemic inflammatory response, with at least 6 months of alcohol intake history. It's often there will be decades of alcohol intake, and the interval between the last alcohol intake and the onset of symptoms should be less than 8 weeks. It is onset of symptoms. And this is the NIA definition. And later this definition has been further subgrouped into definite, probable or possible alcoholic hepatitis based on whether there is a biopsy proof, it's just a clinical without any confounding factors, and it is possible, still a possible alcoholic hepatitis in the presence of confounding factors like drug-induced liver injury, ischemic hepatitis, unclear history, patient not accepting alcohol history, atypical lab reports. The problem with the NIAAA definition is that it has positive predictive value of only 81%, and it can still miss 30% of the cases who actually have alcoholic hepatitis, so false negativity of 30%. And this is the natural history of progression of alcoholic liver disease. Usually 80% of the patients who consume regular alcohol, they just have fatty liver and they continue to have only fatty liver. Only 10 to 20% who develop liver disease, they have clinical or subclinical alcoholic hepatitis. With every episode of clinical or subclinical alcoholic hepatitis, there is higher risk of fibrosis and higher risk of mortality, which increases with continued alcohol intake. This is very important because the mortality rates even in non-severe or moderate alcoholic hepatitis is 6% at 28 days, around 10 to 13% at 1 year, and 50% at 5 years. This is just because continued alcohol intake is the reason for the progression of liver disease. So the unmet needs in alcoholic hepatitis is there is no specific diagnosis. It is a diagnosis of exclusion and history. So and presentation is very variable. Only 2% are eligible for liver transplant or more definitive treatment, and especially the diagnostic biomarker is missing. So I'm sorry for the font, my laptop could not be connected. Ideal biomarker for alcoholic hepatitis should be a molecule or a panel of molecules or in combination, which increase the sensitivity and specificity, distinguish other causes of acute ischemic hepatitis. The biomarker should be defining both the diagnosis and as well as the prognosis and the management. It should identify patients at risk of alcoholic hepatitis, even subclinical and at the fibrosis stage and even the cirrhosis, even prior to the sentinel event. And it should have a very rapid turnaround time with high accuracy. So coming to the topic, emerging biomarkers of alcoholic hepatitis. So we'll go under these headings. The biomarkers which are used for only diagnosis, diagnostic and prognostic and henceforth. So starting with the most basic one, this is ANI score, ALD, NFLD index score. This is very useful in OPD basis when the patient is both obese and also has some alcohol intake and some transaminitis at presentation, to differentiate between whether the transaminitis is because of the alcohol use or because of the obesity per se. So it is just like MELD on online algo, where you enter the parameters like BMI, gender, MCV, AST, LT, and as an example here, when the ANI score is more than 0, it is ALD, less than 0, it is NASH, and it is useful only when the MELD is less than 20. So the next test is in this regard is the ASH test. It is very interesting test. This includes the fibro test, active test, which has 6 components in itself. The LFT parameters, alpha-2 macroglobulin, apolipoprotein A1, and the haptoglobulin, along with added 4 parameters, AST, age, gender, and the algorithms. So it's a non-invasive risk stratification for the alcoholic liver disease. It quantifies fibrosis, steatosis, and steatohepatitis in separate headings. So it can be an alternative to MDF for determining which patients would benefit from steroids. It ranges from 0 to 1, cutoff of 0.5, more than 0.8, more than 80% sensitivity, 84% specificity. When the score is more than 0.84, it is severe alcoholic hepatitis. 0.64 and between 0.84, it is moderate alcoholic hepatitis, and it fares better than matrix discriminant factor in diagnosing alcoholic hepatitis. And regarding when it comes to fibrosis, this test is at par with other parameters which can diagnose fibrosis in acute inflammatory conditions like ELF score, and elastography, they say it is also comparable with elastography. So next interesting biomarker can be breath print. It has been there in publications for last 10 years, but somehow clinically not that useful or used because of the complexity of doing the test. This is very interesting in a way. The smell in the breath of an alcoholic hepatitis is because of TMAO, trimethylamine oxide. So normally the choline content in the food is metabolized by the gut flora into the TMA, trimethylamine, which is oxidized in the liver to TMAO, and which is excreted through the expiration. So the amount of TMAO levels in the breath with a cutoff of 36 distinguishes alcoholic hepatitis from alcoholic cirrhosis, compensated or decompensated. It also uses other volatile parameters like pentane or acetone, and the ROC is very good for the TMA with pentane. So this can be a simple breath test where the expired air is done, mass spectrometry is done on the expired air, which is collected very specifically in specific bags. Coming to the parameters which can also diagnose and prognosticate, the most basic bedside one is the NLR ratio, neutrophil lymphocyte ratio. This is very useful in deciding which patients to give steroids safely. So an NLR score of 5 to 8 are the ones who, when given steroids, they have lesser mortality. When the NLR is more than 8, there is higher risk of infections with higher mortality. So the ideal patients are the ones with NLR of 5 to 8. So it is neutrophil lymphocyte ratio. Coming to the next biomarker, this is the most promising diagnostic marker, cytokeratin 18 fragments. It is both diagnostic and prognostic. It's as we know, cytokeratin 18 is an intermediate filament protein present in almost all the epithelial cells. It is the main component of the myeloid antibodies present on the liver biopsy, and excess serum cytokeratin fragments derived from the hepatocyte death, either by apoptosis or by necrosis. So there are two components of the cytokeratin 18 in the blood which can be seen. One is M65, another is M30. Again, so M30 is a caspase cleaved cytokeratin 18, which is apoptotic marker, and the total M65, it includes the complete cytokeratin and as well as M65 whole together. So that is a marker of total cell death. So M30 is a marker of apoptosis only. M65 is a marker of both necrosis and apoptosis cell death put together. So what has been shown is serum M65 levels, cytokeratin M65 levels with a cutoff of more than 2000 has a positive predictive value of 91% in diagnosing alcoholic hepatitis, and it can also rule out alcoholic hepatitis when the levels are below 641. So as you can see, when the range is between 641 and 2000, that is when we should do biopsy to rule out alcoholic hepatitis. Otherwise, the simple test can rule out or rule in alcoholic hepatitis with a very good 84% of ROC. So the levels of M30 and M65 would differentiate alcoholic hepatitis from alcoholic cirrhosis, and the ratio of M30 to M65, as it decreases, it also represents alcoholic hepatitis. It also predicts survival at 30 days with lesser ratio, non-survivor, higher M30 to M65 ratio, better survivors, and this ratio outperforms MELD in predicting survival in alcoholic hepatitis. So lower the M30 M65 ratio, better the survival. And another interesting thing is, when you look at only the M30, the apoptosis marker, more than 5,000 units per liter, it has predictive. It can predict the outcomes of steroid response. So when the value is more than 5,000, the patients would respond to steroids. If it is less than 5,000, the steroid response would be less. So steroids would work in predominantly apoptotic kind of clinical scenario. So this can be easily incorporated, and maybe we can start using cytokeratin fragments in our place. Coming to genetic markers for predictor, this is one interesting study, although a little old. They have combined MELD with gene signature. It is called GS meld or gene signature meld. And gene expression patterns by microarrays on the liver biopsy integrated 123 gene expressions on all these parameters and added with a baseline meld. They created a score from 0 to 5.32. Scores less than 2.6 good prognosis, more poor prognosis. So what they saw was patients with, and they had derivation cohort and 2 validation cohorts. The values above 2.6 with the GS meld had 96% predictor could predict 96% survival rate in patients who had a lesser score. So they had plans to make a chip and all, but somehow it has not yet come into clinical use or further publications. But more interesting thing what we are regularly seeing here is the association of PNPLA3 with increased mortality in patients with severe alcoholic hepatitis. So the minor allele frequency of PNPLA3 risky recessive genotype is 29% in patients with alcoholic hepatitis, whereas in controls who continue to drink but don't develop liver disease, it is 18%. So it has a odds ratio of 1.8 to be associated with alcoholic hepatitis patients. And additionally, overall survival, 450-day survival in patients who develop alcoholic hepatitis, the GG genotype, the high risk genotype, can predict with a hazard ratio of 1.69 on the long-term survival in a patient who develops alcoholic hepatitis. And this is so even when a patient remained abstinence, the role of genes becomes even more obvious with the hazard ratio of 2.56 in patients who develop even a single episode of alcoholic hepatitis on long-term survival. And the second genetic polymorphism that is very well established is the HSD 17 beta hydroxysterol cholesterol dehydrogenase. This is supposed to be a protective polymorphism and again a recessive one. What is seen is in patients with population attributable fractions, that is actually the proportion of disease in a particular population contributed by this particular polymorphism. With respect to PNPLA3, it is 25% of the cases of alcoholic hepatitis, but when a patient has this protective HSD polymorphism, the risk of alcoholic hepatitis is reduced by 6%. When a patient has both the polymorphism, the risk is attenuated because of this protective polymorphism to 20%. So presence of a healthy polymorphisms can also be looked into patients. And additionally, presence of this polymorphism, the protective polymorphism is associated with lesser prothrombin time, lesser MDF, lesser disease severity, lesser cytokeratin fragments 30 and M65, and better prognosis. So this is just the surface of the genetic polymorphism. With the availability of whole exome sequencing, we should be able to look into further polymorphism which can be associated with better outcomes or worse outcomes. So that if the patient comes with early disease and has these parameters, high risk parameter, we can advise them strongly to stay abstain. And additionally, where the medicine is heading is this small interfering RNAs have been tried, especially in the metabolically associated fatty liver NAFLD patients. Case report phase 1 trial of small interfering RNA acting against the PNPLA3 mutation. A single subcutaneous injection of the interfering RNA to the PNPLA3 GG phenotype patients can reduce the amount of liver fat by 46% at 12 weeks, with a single dose of injection. This has been replicated in American and Japanese cohorts. This is just phase 1. Maybe such things can be available for alcoholic hepatitis as well in future. This is an interesting paper on lipoprotein Z. It's an abnormal free cholesterol enriched LDL-like particle. And this looks like this. This has ApoB, high triglyceride and low cholesterol esters. So what happens is liver not just produces precursors of apolipoproteins, it also produces LCAT and hepatic lipase, which help in the modifications of the apolipoproteins in the peripheral blood. So in what happens in liver diseases is there is also reduction of the hepatic lipase and LCAT enzymes. So modification of conversion of VLDL to LDL is deformed, or deviant LDL is formed, which has higher free cholesterol and lesser cholesterol ester. So that is called lipoprotein Z. It looks different from LDL on various aspects. So what they have shown is they have developed an index based on the LPZ levels and VLDL LDL as denominator, and they have shown that patients with alcoholic hepatitis cohorts, due to impaired lipoprotein metabolism in the alcoholic hepatitis, leads to accumulation of this LPZ in the peripheral blood, which is also known to be hepatotoxic. And what they have shown is the LPZ index score less than 0.6 is associated with better survival, and the LPZ score of more than 0.6 poor survival. And it also has a prognostic value on the daytime. At 2 weeks of therapy, if the Z index reduces by 0.1, better survival. If Z index increases by 0.1, it has poor survival. Predict 90-day survival as well. And coming to the next one, this is our own study, little old. Normally the albumin is not optically active. It becomes optically active when it combines with albumin and becomes elliptical. This ellipticity, as measured by spectroscopy, can predict the survival in patients with alcoholic hepatitis, and the ellipticity value of more than 1.84 is associated with poor survivor. So this was Sukanto's work. And next, coming to the metabolomics with respect to as biomarker in alcoholic hepatitis, this study has looked into untargeted metabolomics as a diagnostic biomarker to identify diagnostic biomarkers. What they have shown is this PGE2 this is pingapin ratio, particular two metabolites ratio less than 1.3 has a very good 96% AUROC with a sensitivity 90, specificity 100%, and this ratio they have suggested to be very important in diagnosing alcoholic hepatitis. Somehow looked interesting, so I put one slide on this. So coming to other biomarkers which can be used, microRNAs. As we know, microRNAs are non-coding small RNAs which are important even physiologically and as well as in many pathological conditions. They can be transferred from one cell to another cell within the exosomes or exosomes. And what the microRNA does is it causes inhibition of translation of the microRNA of the mRNA, and also promotes degradation of the mRNA, so that what proteins are manufactured from a cell is decided by are controlled by the microRNAs. So coming to the microRNAs in plasma in the alcoholic hepatitis patients, with respect to plasma, it has been shown that the particular microRNA 192 is elevated significantly in the plasma of patients with alcoholic hepatitis as compared to the controls, with a high ROC of diagnosis of 95%. And coming to the microRNA profile in the liver biopsy, the PCA graph shows distinct microRNA profile in the liver biopsy of alcoholic hepatitis as well, with which can differentiate it from alcoholic cirrhosis. And it can also identify the levels of the microRNAs in the liver biopsy, can identify the disease severity with respect to the MELD, and also the level of cholestasis with respect to the both hepatocellular or canalicular cholestasis. And also this MIR 182 levels in the blood, in the plasma, can predict the survival with a low level having better survival, and it is elevated even in the plasma. The microRNA 182 levels are elevated in alcoholic hepatitis compared to controls, and also predicts the outcome survival. There are many more studies to look into the microRNA profile. Couple of which I have listed, which can upregulate the inflammation, gut permeability, steatosis, TNF alpha levels, but the data is limited. These two were the more promising RNAs which I could come across. So eventual hope would be manipulation of this miRNA in patients with alcoholic hepatitis to bring down the inflammation can be a future hope, and maybe 5-10 years down the line will be an option. Coming to the next biomarker, gut microbial markers like cytolysine in the gut microbiome. Cytolysine is an exotoxin secreted by Enterococcus faecalis. So it has been shown that in the proportion of the cells, bacteria which are cytolysine positive increases from alcohol use disorder to alcoholic hepatitis. Like percentage positivity of cytolysine toxin production is higher in alcoholic hepatitis, and with the survival is negative when the cytolysine is positive. So toxin producing Enterococcus faecalis in the stool when the gut microbiome decides the outcome, and elevated levels correlates with mortality in alcoholic hepatitis. So what they have also shown in animal studies is in this paper, the bacteriophages targeting this exotoxin positive Enterococcus faecalis will improve the outcome in patients with alcoholic hepatitis. So this can be both a biomarker of diagnosis, severity, prognosis, and treatment as well. So coming to fungal dysbiosis in patients with alcoholic hepatitis, as we can see, the Shannon the diversity is decreased. The number of species is less in patients with alcoholic hepatitis, the fungal species, and also there is dominance of certain small amount of species. As you can see here, in the patients with alcoholic hepatitis, the Candida is increased in numbers in patients with alcoholic hepatitis, and in addition, if we measure the IgA ASCA levels in the plasma of alcoholic hepatitis patient, which is a systemic immune response to fungal products in the gut, is also seen to be elevated in patients with alcoholic hepatitis, with ASCA values with cutoffs differentiating the outcome, and a very good ROC curves with respect to MELD. So simple IgA ASCA levels in the plasma can identify the outcomes or diagnosis. Coming to the bile acids and total bile acids and FGF19 in patients with alcoholic hepatitis, as we can see here, the total bile acids and the conjugated bile acids are elevated in the plasma of patients with alcoholic hepatitis. The same thing depicted here. These are all the conjugated bile acids. And as you can see here, as the percentage of conjugated bile acids goes above 90% to 100%, there is sudden increase in the FGF19 in such patients. So that it gives a feedback to the liver not to produce any more bile acids. So it has also been seen that the level of FGF19 is very high in patients with alcoholic hepatitis, and higher the bilirubin, higher the FGF19 levels. So 19 levels can also be a marker of alcoholic hepatitis with respect to especially the cholestasis. It can be a peripheral marker. Yeah. Coming to the newer digital markers, like artificial intelligence and machine learning models in alcoholic hepatitis. This is a paper under review. We were also part of this study. What they have done is they have developed an algorithm to develop a head model to develop the digital biomarker using AST, ALT, and total bilirubin. They have come to this derivation based on many machine learning tools, XGBoost and random forest and gradient boosting techniques, and with multiple centers, all with biopsy, explant liver, cirrhosis, alcoholic hepatitis, all put together 400 plus patients. And they have shown that the diagnosis of alcoholic hepatitis using this AHEAD model was way better than the NIAAA definition which is currently used. So maybe this is just the beginning. There might be more digital biomarkers coming up in the future to both diagnose and as well as prognosticate the patients with alcoholic hepatitis. So what we can do is we can integrate into our routine clinical practice all these tests, ASH test, TAP test, NLR scoring, cytokeratin, especially this cytokeratin M65 and M30. I think we should be doing this, and definitely we should develop our own data on whole exome sequencing in our patients with alcoholic hepatitis, and maybe lipidomics with LPZ can also be an interesting aspect. And definitely we should look into fungal dysbiosis, bacterial metabolites, electricity. Everything can be incorporated in our place, and with the amount of patients, number of patients we have, and the clinical input we have. So what are the advantages and limitations of emerging biomarkers? They will improve the accuracy, diagnosis, prognosis, and treatment. They are non-invasive and easy to be used and replicated. And limitations wise, it is mainly the cost and availability, and it needs further validation, of course. So to summarize, alcoholic hepatitis is a unique and severe manifestation of alcoholic liver disease. There is an inevitable need to develop reliable and non-invasive biomarkers with rapid turnaround time, and so that for diagnosis, prognosis and treatment can be better with a target to achieve precision medicine in alcoholic hepatitis.